Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast Network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast. Ozcast. Simply head to ozcastnetwork.com for details.
Hi, Steve Davis here. Just a quick word before you listen to this episode on BRCA. It began its plan as a nice, small, self-contained episode, but it has grown, thankfully, to the great generosity of experts around this country. So we've broken it into two parts. So here is part one, as we look into breast cancer history and start looking at treatment. And then part two will be episode 31, released a fortnight from now at the time of recording. Dr. Travis Brown, what is this medical life all about?
This is the pursuit of knowledge as we learn about diseases from the ancient times to the present day. These are the stories of medicine.
Dr. Travis Brown, in the general realm of medicine, I tend to get the impression that most diseases are diminishing from my layperson's view as we get further and further advanced into lifestyles, prevention, etc., treatment. Breast cancer, not so much. The incidence is increasing.
That's right. The fortunate thing about that is, whilst it is increasing, we're actually getting much better at treating it. So the mortality rate associated with breast cancer is reducing.
Right.
So most things as we progress in medicine, we are actually getting much better at identifying it early, getting intervention early, and then managing it, and hopefully stopping or at least preventing as much advanced illness as possible. And look, breast cancer has been a topic that I've wanted to do a number of times, but it's such a large topic. Breast cancer is the most common cancer in women, and it's a huge topic. And so what I've decided to do is take an aspect of breast cancer and really explore that, and probably do that in the future with other breast cancer and
right, so we've got more angles to come back to more thoroughly exhaust the topic over time.
That's right. So it's not something that you can just cover in one big shot. Yeah. And this topic is actually on familial breast cancer, and specifically the BRCA mutation gene. And so it's one of those things that most people will know about. They'll be familiar, at least, with that. And that's probably it's an excellent thing to actually, for even lay people to know about BRCA gene. And it's like, is that the breast cancer gene? And it's like, imagine lay people knowing about that. And so that's how remarkable it is. But if we look back at familial cancer, particularly familial breast cancer, the first time it was noticed was in 1866. Ooh. And this was a French physician. His name was Pierre Paul Broca. And he wrote, it was a Traité des Tumeurs. And what it was it actually was his wife's family's history.
See, yet again, our insights into medicine historically, and even in current times, can often be from the personal experience of the researcher.
Well, that's right. And what he noticed as a physician was that a grandmother and a mother and a daughter could all suffer the same disease. And this was breast cancer in this case. Mm-hmm. And so he ended up doing a family pedigree, a family tree, and he called it Family of Mrs. Z. And he ended up between 1788 and 1856. He traced 51 of his wife's relatives, which, when you think about it in those days,
that's a lot of work
for a physician who's clearly personally affected by this. And the interesting part is that conventional wisdom at that time was you can't get cancer before the age of 30. And so this is sort of a demarcation that he said, well, they're 30, these people were over 30, these people were under 30. Yep. And the estimated incidence or prevalence of cancer at the time was about 3% for people over 30. And he calculated that this family, his wife's family, had a 15 times rate of that. So there was something there that he looked at, and he's gone, why do we have so much cancer? And he ended up looking at 26 family members over the age of 30, and 15 of them developed cancer, and the majority was breast cancer. And so he looked at the average age of the people who died at this time, and it was 49 years. Now, that actually sounds really young to us, but over there at that time in France, the average life expectancy was 35. Yeah. So it's sort of it's unusual because I'm guessing must have been quite an affluent family to be able to live that long and that be considered then short for them. But in his writings, you can see him struggle to understand this deadly disease.
Whatever the name one wishes to call it, this deadly predisposition, impossible to foretell, impossible to escape, inaccessible to surgery, and until now even inaccessible to internal or medical treatment, is an indication of a general state which precedes each local manifestation which persists after surgery and which determines a recurrence in the same way that it produces the first tumour. When one looks beyond, in certain cases this predisposition transmits itself by heredity through several generations. A person in whom are assembled unknown conditions which expose him to later become cancerous can transmit to his posterity this group of conditions before they've even manifested themselves in him. Also, having received the diathesis from one of his forebears, he may escape during a long and healthy life the consequences of that hereditary state and may pass on to his children the disease from which he was spared. A remarkable fact about the inheritance of cancer is the perfect health which is enjoyed for many years by persons who carry the germ of this illness.
I mean, the interesting thing is when you were practicing reading that before, I did notice that he refers to, even though he's referring to breast cancer in women, he still refers to him, but that's just the male.
That's true. and please don't let people know I rehearse that.
And so the point behind it is you can hear him struggling with what he later described as someone in perfect health suddenly would have an explosion of disease. Yeah. And they would die within 1 to 2 years. And so he could not work out how this effectively was a time bomb, as what we would say, as to going from good health to not. And so he's actually talking about, and even there he talks about, he could even skip a generation.
Yes.
And so he really is struggling to come through it. And we next find the next major significant finding in 1926, and this was through the study conducted by Janet Jane Clapon. And now she was a remarkable woman. She was a renowned researcher and a doctor, and a doctor at that time, again, was pretty difficult because, again, a few decades before, they didn't allow women into medical studies, and she was the first woman to receive a research scholarship from the British Medical Society, so she was a pioneer. She ended up writing a report called A Further Report on Cancer of the Breast, and she did a study on 500 hospitalized patients and then 500 controls, and found out many of the risk factors that we know today as risk for breast cancer, including family history. And so there is a trait that starts to come, and that brings us to the 1970s. We started to get epidemiological studies and a subset of patients that says there is familial clustering of people with breast cancer. And particularly, there was an interesting aspect of some patients had an increased risk of breast cancer and ovarian cancer. And of particular interest with this was first-degree relatives. So if you had a relative that had either of these cancers, yes, your risk was increased. And so that brings us into the 1970s and 1980s, and we find Professor Mary Claire King, who is now a professor of genome science and medicine at the University of Washington. And she at the time was searching for a genetic link. Now, the prevailing wisdom at that time was that breast cancer probably had a viral etiology. And when you think about it, it's not so unusual because things like cervical cancer has a viral. So that was the prevailing wisdom, or thought this might have a viral cause. And she thought otherwise. And what she ended up doing was getting a bunch of families who had strong clusters of breast cancer, and she believed clearly had a genetic link. And she investigated, and the problem is at this time, we're talking 1970s, genetic techniques were not what they are now. And so to find it would have been just very difficult. She ended up getting, it was 23 extended families, 329 relatives, and this included 146 cases of breast cancers. And she, in choosing these patients, she focused on breast cancer, people particularly with a young age, who might have bilateral disease, so both breasts affected, and who had increased affected males in the family. So she ended up with the team genotyping 173 different genetic markers. And again, should be emphasized, the techniques are not what they are today. This is not simple. And they found a region on chromosome 17, it was 17q21, that found a co-inheritance that was consistent in people who had relatives affected and had breast cancer. And so the next challenge was to clone the gene, and in 1991, they ended up calling it BRCA1 gene and identified that these people had an increased risk of breast and ovarian cancer. And a few years later, there was Michael Stratton and Richard Wooster who identified the BRCA2 gene, which is on chromosome 13. And this is where we find ourselves. And these patients have increased risk of malignancy, particularly breast and ovarian. And it's really important because these families, it's associated. And so we know that these people are at increased risk. The interesting aside thing about all this, and needs to be mentioned, is this was also when the US company, the Myriad Genetics, patented BRCA. And this was in the late 90s. And they ended up saying, well, we own the gene because we know about it. And fortunately, in 2013, that was struck down by the US Supreme Court and said you can't actually own a naturally occurring gene, which is just really good because it meant that they were the only ones who could do the research on it. But we are at a point today where we know about this gene, we know about the risks that patients have to it, and we are now understanding the implications for patients, for families. And today we have a set of specialists to help us understand what we really need to know about BRCA.
And before we get to them, no disrespect to you, Travis, but we're touching on genes. I think we need to see if we can get Professor Graham Southers to join us next. Professor Graham Southers is the National Director of Genetics for Sonic Pathology Australia. He trained in clinical and laboratory genetics in Sydney, Adelaide and Oxford, and held senior appointments in the South Australian public sector prior to his appointment with Sonic. His current role involves the development of genetic services for patients and families across Sonic's clinical and laboratory services Australia-wide. He's a regular guest. We always enjoyed talking to him. Welcome back, Graham, to This Medical Life.
Thank you very much, Dave.
Graham, I'd like to start with getting your take on the prevalence of BRCA1 and BRCA2.
That should be a simple question to answer, that you simply line up a lot of people in the middle of some shopping mall and do a blood test and see how frequently the mutation crops up. And if you do that in the Australian context, then there's about 1 in 300 or so people will turn out to have a mutation in BRCA1 or BRCA2. But the reason I flag a bit of a hesitation there is that the frequency varies in different populations. And we have very good data from the Ashkenazi Jewish population that about 1 in 50 people from that community, from that ethnic group, carry one of these mutations. And there are other populations that have a comparatively high rate of these mutations. Now, that variation could be due to a variety of historical factors and so on. But it does mean that when I talk to the average Australian, if you will, I am already factoring in to a certain extent what I understand to be their genetic ancestry as best I can. Now, genetic ancestry is not an easy thing to quantify, and we're actually, people are not very good at knowing their own genetic ancestry. So I'm not suggesting we can put a lot of weight on what someone says of their ethnicity or genetic ancestry. I'm just noting that it's not a simple thing to provide you with a clear answer to your question for an individual person, because that will vary according to their genetic context, if I could put it that way.
Looking at the role then of the BRCA genes, what role do they play?
The BRCA genes have been identified for almost 30 years now, and so I'm not going to be able to give you a précis of the latest 28 years worth of research in this, because it is a huge area, Travis. The two genes have an important role in the repair of DNA. DNA, as we've discussed previously, is a very long, thin strand of genetic material. And when breaks occur in that strand, and they do, there are exquisite mechanisms within the cell for repairing these breaks. And the BRCA proteins produced from these genes are intimately involved in that process. But if you want more detail than that, this is where you really need to have a cell biologist on your podcast who could then dive into the almost 30 years now of experience that people have had in exploring this. And it's been a fascinating and clinically very productive area of exploration.
Looking at, because we've mentioned it now, BRCA1 and BRCA2, is there any practical reason a clinician needs to know? I know oncologists and surgeons will need to know, but is there any really useful reason for knowing the distinction between, this patient has BRCA1 and BRCA2? I remember having to remember, this has implications of, this has higher breast cancer, this has higher ovarian cancer. Is there any practical reason for noting the distinction between 1 and 2?
The short answer is, for the general practitioner, probably not. That the key thing to be aware of is that there is an increased risk of cancers, plural, and it's not just breast cancer. And so it's more to, we discuss this with the general practitioner community, more to raise their awareness of familial predisposition to cancer, and that it's not necessarily straightforward to diagnose, rather than because we want them to be up on the precise risks for a particular person having a particular mutation in a particular gene. As we move to the specialist environment, where we're now considering some targeted interventions for a person who has a mutation in one of these genes, then the distinctions can become helpful in terms of prioritizing tasks as to what might need to be discussed sooner rather than later.
Mm. Is there differences then in severity of BRCA gene mutations? Because they're big genes. Is there something such as this is a severe mutation, this is a less severe mutation?
I'm going to give you two answers. I seem to be doing that a lot today. I'm sorry, it must be because it's Tuesday. But the two answers, the first one is there isn't a striking difference. So that if you go and look at the mutations that are now catalogued in international databases and so on, they're generally assigned the same degree of risk. And that's a pragmatic clinical response to say this person has a predisposition to develop cancer on the basis of this mutation, but we try not to get too precise about that in terms of exact numbers for an individual, because there are variables, and one of the variables is the exact type of the mutation. Now, we've got a problem here, Travis, so that if you want to compare the significance of this mutation versus that mutation, you need quite a large group of people who have each of those mutations, and where you have sufficient information about them, their lifestyle, other genetic factors and so on, to be able to factor all of that into place. And that's a hard ask, and to a large extent has not been pursued. So there may well be some relatively subtle differences in the significance of this mutation versus that mutation, but quite challenging to sort that out. Now, I think that this will change as more research is done over time, and that's the old mantra that you can keep on doing more research. Good research provides new questions, so you can keep on doing research. And so I think over time we will come to recognize that there are variants within the BRCA genes that do not appear to carry this strong familial predisposition to develop cancer, but are a milder risk factor. And that might be an indirect way of answering your question.
Mm-hmm. Can I ask then, what are the risks of a patient having BRCA mutation?
So the chance that a person has a BRCA mutation, it will start at, let's say, a population risk of 1 in 300. So if we take Joe or Jane average off the street, in the Australian population, they have about a 1 in 300 chance of having a BRCA mutation. Now, that number could potentially, or that probability could potentially be pushed lower if we carefully selected Joe and Jane averages who, in fact, are not average and have no family history of breast or related cancers, let's say in first, second, or third degree relatives. So we could identify people who are at lower than average risk because they have a family history that does not have cancer, but it's not going to be an absolute thing because some people in the family may have a gene but not get cancer because of good luck or because they die early of something else. So this becomes very much a mathematical exercise rather than a person-specific response. But of course, if we look at it the other way around, if we take Joe or Jane average and there is a family history of breast or ovarian cancer among close relatives, particularly if that is early onset breast or ovarian cancer, then we start increasing the chance that the person that we're talking to actually has that mutation, or has a mutation, I should say, in one of those genes. Now, there are a variety of tools that have been developed for clinicians to use to make this assessment. And it becomes important because the testing of these genes is not straightforward. It's a relatively expensive exercise. It is rebated by Medicare these days, but Medicare itself says we will rebate the testing for these genes if a person has breast cancer and has a greater than 10% chance of having a mutation in one of these genes. So we need to have, the specialist needs to have some tool to decide whether the person that the patient they're talking this over with actually fits that, fulfills that criterion. So there are pencil and paper scoring methods, and some of these are listed on, one of these is listed on our Sonic Genetics website. There are also computer programs that are very sophisticated, or they range in sophisticated. There's some fairly basic ones. I think Cancer Australia has one on its website. There are some excellent programs that are becoming quite precise in terms of the degree, the probability of having a BRCA1 or BRCA2 mutation and the risk of developing breast or ovarian cancer for this person over the next 5 years, etc. But the more complex the response you want to get back, the more information you have to put in to start with. So those more sophisticated programs require more engagement by the specialist and are typically used for research purposes rather than in the consulting clinic.
Mm. So these patients have increased risk of malignancy. Is it just breast and ovarian, or is there anything else we should be aware of?
Yeah, look, that's the short answer is yes, there are other things. There are other cancers that can crop up. And the story in this has been evolving over a very long period of time, over that period of 30 years. The families were initially identified on the basis of having a strong record of breast or ovarian cancer, or both for some women. But in identifying these families, it then became clear that there were other cancers occurring. And the challenge was, we've now got big families that we've identified for research purposes to track down these genes. Are these other cancers incidental, or are they in fact related to the presence of the BRCA1 or BRCA2 mutation? Now, that's been quite a challenging thing to sort out because you do need a lot of families to work this one out. You need to be collecting information prospectively over a long period of time as well as retrospectively. It's complicated by the fact that over time more interventions are being done. So we may see less bowel cancer now than we did 10 years ago because people are more aware and having colonoscopies, or we might see less breast cancers because people in the family are now, the women in the family are now having mammograms or whatever. So there are some things that can come in and confound the sort of studies that we need to do to pick up to answer the very question that you're asking. I'll add one more, and then I'll try and answer your question for you. And that is that it would appear that there is an increased risk of melanoma among BRCA carriers in Australia, but not necessarily overseas. And the problem here may not be a difference in biology, but a difference in sun exposure. So I'm just noting that we have good information, robust information about breast and ovarian and prostate cancers in these families. So prostate is an important one for the men. And men, by the way, can also get breast cancer, and it does occur at slightly increased frequency in men who have a BRCA1 or 2 mutation. There appears to be an increased risk of pancreatic cancer, particularly in people who have a BRCA2 mutation. But we're very quickly getting to the space, as it were, where there's a long tail of cancers which may occur more frequently, but it's still relatively unlikely that an individual person with BRCA1 or 2 will develop that particular type of cancer. There's been some debate as to whether bowel cancer itself occurs more commonly. That's sort of still being discussed and debated, but there's been some publications around that. I've already flagged the melanoma possibility, and there are other cancers that appear to occur at slightly increased frequency, maybe gastric cancer and so on, but we don't have a lot of hard information about this for the reasons that I have flagged.
Going back to just basics of genetics, what's the inheritance pattern of BRCA?
So the BRCA1 and BRCA2 mutations are inherited as autosomal dominant mutations, autosomal dominant traits. And just to remind you, Travis is a mere general pathologist, that autosomal dominant means that he can beat me up later, Steve. The autosomal dominant means that the presence of one copy of an abnormal gene is sufficient to cause a problem. You'll remember that most of our genes occur in pairs. We get one from each parent. And an autosomal dominant disorder is one where a mutation in just one of a pair of genes is sufficient to cause a problem. And that distinguishes these dominant disorders from other conditions where you have to have a mutation in both copies of a gene. And it's a story for another day. So in terms of family inheritance, this autosomal dominant mutation can be passed from parent to child, and each child has a 50-50 chance of inheriting the abnormal gene. But I've emphasized there that I'm talking about the inheritance of this mutation within a family. So from the family perspective, this is autosomal dominant, 1 in 2 chance of mutation being passed to a child. But if I'm sitting inside the cell of someone who has a BRCA1 or 2 mutation, I'm sitting there in this tiny space, a micrometer or so across, and there are 2 copies of, let's say, the BRCA1 gene. One is abnormal and one is normal. Now, while the normal gene is still intact and working, the cell is actually functioning normally. What happens, though, is if that second copy falls over, if it stops working because of a chance genetic error that knocks it out, then we have 2 abnormal genes within the cell. And that means that there is no active copy of in this case, the BRCA1 gene, and it's that loss of BRCA1 activity in the cell that is the precursor for the malignancy that frequently develops. So we have a situation where this mutation is inherited on a family sense in an autosomal dominant fashion, 1 in 2 to each child. But within the cell, it acts like a recessive condition in that you have to lose both copies of the gene for it to actually cause the problem that is the hallmark of this condition.
So when diagnosing someone, we have the testing that comes on in. Is there a distinction or is there a difference in your viewpoint for a patient who might be less than 40 to 60 or 60 above? Does it mean anything differently for someone who's positive in those age categories? We've tested them. They're either under the age of 40 and they're positive. Does it mean anything different for someone who's 30 to someone who is 70?
Yes. It absolutely does. And the striking thing is that for someone under the age of 40, the relative risk of developing breast cancer, let's say the risk of this woman compared to other women of her age who don't have that mutation, that relative risk for breast cancer is very high indeed. And so the major clinical concern for a woman under the age of 40 is concern around breast cancer risk and surveillance for that. Clinical examination, MRIs, mammograms, and for some women, they will choose to take the course of prophylactic mastectomy with or without breast reconstruction to reduce that risk of developing breast cancer. And there are also some hormonal strategies that can reduce the risk of breast cancer. So they're fairly serious undertakings, and the reason that we have that focus on breast cancer is because of that high relative risk. Now, these women are also at increased risk of developing ovarian cancer under the age of 40, but when you compare it with the breast cancer risk, the ovarian cancer risk is much lower. I can't dismiss it or make it disappear, but it's very much lower to the extent where interventions to, for example, remove the ovaries, which is one strategy that could be considered, whilst it's worth having that discussion with a woman of that age, it's not the priority in the discussion. Now, as a woman moves from her 30s into her 40s, the priority of that discussion switches, and by the time you're dealing with a woman in her 50s, the risk of her developing, a relative risk of her developing breast cancer is much lower. It's still higher than, there is an increased risk, don't get me wrong, but it is not as strikingly increased as it is in the younger woman. Whereas what we're seeing is a rapid increase in the risk of developing ovarian cancer. So by the time a woman reaches about the age of in her mid-50s to 60, she's at greater risk of developing ovarian cancer at that stage than of developing breast cancer. And so the priorities for intervention and for surveillance obviously shift.
Mm. Graham, can I ask, what are the risks for men who are BRCA positive?
Male breast cancer is uncommon. We find that about 1 in 1,000 men will develop breast cancer by the age of 70. That's in the general population. Now, that's increased about tenfold to about 1 in 100 men who have a BRCA1 mutation, and anywhere between 5 and 10%, so it's increased even further for men who have a BRCA2 mutation. So it still means that the great majority of men with BRCA1 or BRCA2 mutations do not develop breast cancer, but there is a small, significant proportion who will, and male breast cancer in the past was typically diagnosed quite late in an advanced stage because people thought that men don't get breast cancer, and in particular men thought that men don't get breast cancer. But if any man has a persistent lump under either nipple, then that needs to be investigated. And one of the concerns for a specialist or GP examining a man with a breast lump is this possibility of male breast cancer.
Mm. Looking at it from the GP perspective, particularly when someone has a strong family history, when is it appropriate, or is it appropriate for a GP to start testing for BRCA?
That's a good question, and it's quite a challenging one to answer. We've got I'm going to give you a professional response, a pragmatic response, and a Medicare response. And the reason that I'm being so coy about this is that there are rules around the Medicare rebates for this type of testing. There are also professional guidelines about the significance of this type of testing. And I accept the concern that we need to be sure that people ordering this test, the doctors ordering this test, understand the implications of the test in medical terms and in psychological and other terms for the patient, and that those doctors are sufficiently experienced to be able to arrange this test wisely, if I can put it that way. But I'm going to add a third element into the mix, which is the pragmatic one, that we need to have healthcare that is accessible. And the general recommendation at the moment, and the Medicare requirement, is that this type of testing is initiated by a medical specialist. And I can see good merit in that on professional grounds. So there's both the Medicare and the professional element to it. However, if it's going to take 6 or 12 months to get to see a specialist, then that's a real problem. That's a problem of access. Or if you live in a regional or remote area around Australia where you need to travel some hundreds of kilometres to have a blood test taken, essentially, I think that represents some significant barriers. So the official party line is that this testing needs to be ordered by a specialist, and there are very good financial and professional reasons for doing so. But I am concerned that we as Australian healthcare providers are not necessarily meeting the needs of everyone who could and perhaps should access this type of testing.
Just coming down to actual cascade testing with families, it's going to be something we cover in a future podcast, but is there just something that you can say about when is cascade testing appropriate and who it can be ordered by?
Cascade testing for the BRCA1 and BRCA2 mutations is something that, in general, need not be considered during childhood. We have spoken previously on these podcasts about conditions where there is a clear reason to test during childhood because there are interventions that can be applied during childhood with good benefit. And this is not the situation of the BRCA1 and 2 story. So this is really an adults-only space where the testing is recommended when a person has the maturity to be able to make their own choice as to whether they want to have this test performed. And it's not a trivial undertaking to have this test, and careful pre-test genetic counselling is important so that the person can make an informed choice to either have the test now or not have the test now, but may want to retain the right to have the test in the future. And those are all very reasonable options. So this type of testing is best done through a familial cancer clinic or equivalent program where there are genetic counsellors and clinicians who have experience with this condition who can help the young adult make a decision in their best interests. Now, I did flag young adult there because I mentioned that for a woman under the age of 40, that this increased risk of breast cancer is quite dramatic. And you really need to be on top of that if you want to get ahead of the problem. So what would be tragic is for someone to say, look, I'll defer having this test until maybe I've sorted out my career or done my postgraduate thing or travelled overseas or whatever it might be. But breast cancer does occur in the 20s, particularly in the context of these mutations. So my recommendation is that a discussion be had in a person's late teens or early 20s, where they then make an informed choice as to when they will revisit the matter or whether, in fact, they'll proceed with testing at that point. But I think that it's important to raise this as an issue with young adults and not put it off.
And just before we bid farewell to you for this visit, Graham, are there any tips or any advice for GPs to know about BRCA mutations?
The key thing, Steve, is to recognise that the world is changing. So when I was a boy in short pants at medical school, there was no such thing as familial breast cancer. Familial things affected children, and we didn't really think of the genetics of adult onset disorders at all. It's a great tribute to Mary Claire King and her colleagues who sort of led the search for these genes back in the 80s, that they turned that paradigm on its head and pointed out that adult onset disorders can indeed be familial and strongly familial, so that you might have a person who lives 20 or 30 years without developing a condition, but when they do develop a condition, it is still due to an inherited predisposition. So my take-home message for every clinician is to be aware that the genetic basis of disease, we're getting more and more insights into this. So do not rely on your old knowledge. Bring a new pair of eyes to the situation that is before you today and ask the question, could there be a familial contribution to this patient's story? And if the answer in your mind is there could be, then pick up the phone. That's what what pathologists are for. That's what medical specialists are for. There are all sorts of resources to help GPs. We're not expecting general practitioners to be experts in this place, but we are hoping that GPs will pick up the phone and ask.
Wow. Graham, thank you again. And thank you also for the turn of phrase you used a little bit earlier about an adults-only space. Travis, we might use that as the tagline for this podcast. What do we think?
Maybe not.
Maybe not. Professor Graham Sanders, thank you as always.
Thank you, Steve.
Melissa Bochner is a breast and endocrine surgeon who presently works as head of unit at the Royal Adelaide Hospital and also attends St Andrew's Private Hospital and the Women and Children's Hospital here in Adelaide. Melissa trained in general surgery in New South Wales, where she attained her fellowship of the Royal Australasian College of Surgeons in 1995 and completed a Master of Surgery research at the University of Sydney. Melissa underwent 2 years of specialised post-fellowship training in breast and endocrine surgery, attending the Royal Adelaide Hospital and the Edinburgh Breast Unit. She spent over 10 years as a specialist surgeon at Breast Screen SA and as a clinical title holder at the University of Adelaide. She's also a member of Breast Surge ANZ and current chair of the Breast Cancer Quality Audit. Dr. Bochner also has an interest in research and teaching, also being a guest reviewer for a number of peer-reviewed journals. I hate to think how she's going to review our podcast. Today, Dr. Melissa Bochner is our guest on This Medical Life podcast. Welcome, Melissa.
Thank you so much for having me. And I've heard some of your podcasts, and I'm going to give them a very favourable review.
I can now relax. Now, we're discussing inherited breast cancer today, specifically in relation to BRCA. In your practice, is this something you come across a lot?
It's increasingly prevalent within our practice as knowledge of breast cancer genes increases. And of course, as you've said, BRCA1 and 2 are the ones that we've known about the longest and the ones that we would see the most. But there are increasingly new genes related to breast cancer being discovered. And so we are seeing more and more people either with a family history or with a proven gene.
Looking at the status of someone with BRCA, is this something that you find out as part of your process, or is this something they come to you with knowing?
It's different for everybody. So sometimes a person will know that they come from a family that carries that gene and that pre-symptomatic testing is available for them from an early age. So we see a significant number of women with a family history of breast cancer, a known family member with BRCA1 or 2 who have had testing themselves and who come in for a chat about how they should be managed. The other group of women, of course, are the women who might be diagnosed with a breast cancer and for some reason we feel that they could be a gene carrier, either because of a family history that has not been investigated or because of the particular subtype of their cancer, in particular the grade 3 triple negatives in a young woman, would make you think about genetic testing. So there will be a group of women with a newly diagnosed breast cancer that we will initiate genetic testing in at the time of diagnosis and find out they're a gene carrier at that time.
I imagine there's much anxiety and concern when patients come to meet with you. I'm curious to know what the most common questions are that you get asked by patients about BRCA.
Do you mean the people with the new diagnosis of being a gene carrier without yet having breast cancer?
Yes.
I think that a lot of those people come with a very strong background knowledge of what the gene might involve because they've seen their family members go through certain treatments or certain diseases, and so they will have an opinion, and then that will inform perhaps what they want to do for themselves in terms of either surveillance or risk reduction. So clearly the fears for people surround the early development of breast cancer, the effect that might have on their length of life, the effect that the treatments might have on them, in particular chemotherapy, and of course questions surrounding risk-reducing treatments, in particular risk-reducing surgery such as double mastectomy.
Now, focusing on a person who has been diagnosed with BRCA, is there a different management for patients who, let's say, are less than 40 and maybe between 40 and 60 or even 60 plus? Is there any different management for these patients?
I think there is. We know that traditionally we've spoken to people about what we call their lifetime risk of developing breast cancer, and clearly for BRCA carriers that's quite high. That might be as high as 70 or 80%. it's important to try and break that down for people in terms of what is their risk of developing breast cancer in the next 1 year or in the next 5 years rather than total lifetime risk. And in fact, when I looked at the figures that we have on our database at the Royal Adelaide for breast cancer diagnosis in our gene carriers, the median age of diagnosis is about 40. So we need to look very carefully at screening women, particularly from the age of about 30 up to 50, and that's clearly outside of the normal screening age. So those people need to be treated differently to the normal screening age people. Once you get over 50, of course, if you have not yet had a breast cancer, then screening may be along more what we call standard lines for the general population. So there are differences in screening, for example, use of mammogram versus use of MRI, considerations of radiation dose, of breast density. We need to think about how we manage people at a time of their life when they're obviously thinking about or having a family. So screening in women who are pregnant or who are breastfeeding, maintenance of fertility in people who are looking at having treatment or risk-reducing medications in particular. So yes, there are a lot of differences based on age.
Okay. Looking at, let's assume two women come to you who have exactly the same mass in a breast. One's BRCA positive, one's BRCA negative. Is there any difference in the management of those two patients knowing that status?
So if someone has a newly diagnosed breast cancer, then most of the treatment decisions are based around, obviously, the patient factors, so their age, their fitness, and so forth, but also around their disease factors. So all breast cancers these days would be subjected to a preoperative core biopsy, and on the core biopsy we would have, therefore, information about the type of cancer, ductal versus lobular, about the grade of the cancer, and about the receptor status, estrogen, progesterone, and HER2 receptor status, so that you then make a decision about whether that woman is most suitable, for example, for upfront surgery, or whether she should be having neoadjuvant chemotherapy. Neoadjuvant chemotherapy is often preferred for women with triple-negative breast cancers in particular. So if you take a BRCA triple negative and a non-BRCA triple negative, then both of those women would probably be offered neoadjuvant chemotherapy, followed by surgery and with radiation as required. Having said that, there are some differences in the type of chemotherapy that might be offered, because we know that BRCA carriers may be more amenable to certain chemotherapy drugs compared to others. And so that would be a definite conversation that she would have with her medical oncologist. And there is, in fact, a new drug available called olaparib, which is not being routinely used in clinical practice. But again, in Adelaide, we're about to start a clinical trial, perhaps using this drug in the neoadjuvant setting for gene carriers. So yes, there are differences in the treatment of gene carriers, even with the same disease.
So then one of the things about people with gene predispositions, there's a lot of discussion around prophylactic operations. So we're talking about mastectomies and oophorectomies, particularly with BRCA. When is that appropriate to have that discussion with patients?
I think when you're talking about an asymptomatic carrier, it is very important to have a very good rapport with that patient and to really get on their wavelength. There is so much for them to think about, and risk-reducing surgery, of course, can be life-saving, but it's also extremely invasive and a very emotional thing for that woman to put herself through. So it is not something that you just have a 10-minute consult and book them in to have it done. We would see them, have a general talk to them about risk management, about options. And I think it is very important for women to understand the difference between surveillance, where we would try to pick up a cancer earlier, versus risk reduction, where we're trying to stop them from getting a cancer. And clearly surgery falls into the risk reduction side of things. Clearly, the further you go, the more impact those treatments have. So initially I would just talk to them about what the options are and mention that surgery is one of them. I would make sure that they were on an appropriate surveillance program, because we need to know that they haven't got cancer now, which then gives them time to have a think about what they want to do in terms of risk reduction. Risk reducing breast surgery will usually be bilateral mastectomy, and then you have to talk to them about whether they would like to have a reconstruction in association with that. Once you start talking about reconstruction, there are a lot of different possibilities in terms of the type of reconstruction, and they need a lot of information before making a decision. So I think it's really important not to rush it.
Mm-hmm. Thinking about then, most patients with this will be female. Do you see many male patients who are BRCA positive?
No, we don't see them. And clearly, it's not a gene that discriminates. So there will be as many men out there that are positive as women. But because their cancer risk is less, because they don't get as much breast cancer and they don't have ovaries, there is not a formal screening program or recommendation for men with breast cancer. With breast cancer genes. Having said that, I do have a couple of men that I see for just an annual breast check, which improves their peace of mind, and men are told about self-awareness and reporting symptoms. But we do not have formal programs for men in the same way that we do for women.
Mm. So if someone was to come to a GP and turn out to be testing, familial testing, and they've come out BRCA positive, when is it appropriate for them to be referred to a surgeon?
I think they should be referred as soon as they know, because that gives them a lot of that time I was mentioning before to have those chats and a lot of thinking time, and doesn't get them into a situation where they've suddenly got a lump and they don't know what to do about it. So I will see someone from as soon as they know they're a gene carrier, and that might be to have a preliminary chat with them when they're 19 years old, and to say to them, well, this is what we're going to recommend, and we're going to put you on a program, and we'll start doing an MRI and we will come up with an age that works for them. That might be a little bit based, for example, on their family history. So I might say, come back when you're 25. So I might not need to see them in between, but they've got someone that they can touch base with, and they've got a specialist. So I think, yes, they should be seen as soon as they can.
Is there any general advice or some tips you might have for general practitioners regarding BRCA in patients?
In terms of managing them?
Anything that would just help with their awareness of this and some confidence of questions to ask or directions to consider.
I think that the breast cancer gene area is difficult, and it changes a lot. And I think I know that you've spoken to Graham Southers, and he would have told you that there's always something new, that people that may have been gene tested 5 years ago because they had a suspicious cancer and found to be negative may turn up with a new gene 5 years later. So I think that it is really difficult for GPs to know who to refer and who not to refer. In fact, I think the definite gene carriers are easy because they can refer them on for specialist management. It's the people with the strong family history and no proven gene that is very difficult for GPs to know what to do. And some of those women need to be under specialist management. Sometimes I will see a woman for advice because she's a younger woman with a family history of young breast cancers. Give the GP some screening advice about the frequency of imaging and the type of imaging, which is essentially choosing between MRI and mammogram, and then let them go back to the GP for management. But I do think that's very difficult. In terms of the specific gene carriers, I do think that they should be on a program. They should be given a surveillance program, and they should have a regular contact with a specialist so that they are given the most up-to-date advice about screening and risk reduction. The other thing is that we do sometimes have clinical trials available to gene carriers. And for example, at the Royal Adelaide at the moment, we're offering a trial called BRCA, which is a drug trial for BRCA1 carriers only using a drug called denosumab. And you can't really find out about those trials through the GP. It's too much to expect them to know everything about it. So I do think staying in touch with the specialist service is good. At the Royal Adelaide, we have a dedicated high-risk clinic for breast cancer gene carriers. It's a multidisciplinary clinic where we have both gynecology and breast in the same clinic, so that women only have to make one visit, and they can talk about all their options on the same day rather than coming back and forth all the time.
Wow. Dr. Melissa Bochner, thank you for taking some time out to enlighten us in these areas. We really appreciate it.
Oh, it's been lovely. Good luck.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts via Twitter. Dr. Travis Brown is at Dr. Travis Brown. That's DR for doctor. And Steve Davis is at Steve Davis. Editing and production is by Tim Whiffen. Design is by Tom Buzenjut. This has been a Pathnotes Proprietary Limited production.
Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.